All right, we got the bite-sized presentations. We're going to start with wonderful Kate Dobler. Let me start with a quick bio for her. Kate earned her bachelor's degree at the University of Arizona in Family Studies with an emphasis in child development. After joining First Things First in 2008, she earned her certificate in public management from Arizona State University in 2015. She holds a master's degree in educational leaderships with a focus on community college and higher education from Northern Arizona University in 2019. In 2020, she joined Access as a project director for the state pilot project for the treatment of pregnant and postpartum women diagnosed with substance use disorder, and is driven to improve the odds of Arizona's mothers, babies, and their families. Thanks, Kate.
Thanks so much, Tammy. I appreciate the intro. I'm gonna share my screen, and I'm gonna hope that I can configure this correctly. Brianna, can you give me a thumbs up if this worked, please?
Yep.
Yay,
Yeah.
excellent. So yes, my name is Kate Dobler. I am now the project director for Arizona's state pilot project for the treatment of pregnant and postpartum women diagnosed with substance use disorder. And I am working for Access. So this project, some details of the project itself. So this is originally a SAMHSA funded project. It is funded under the substance abuse block grant on the treatment side. And it is a discretionary funded project that Arizona had to apply for. And we were one of 5 states funded in 2020. So our, which coincided with the position being created for which I applied. So the project begin date was August 31, and we are of 2020, and we're funded through August 30th, 2023. So we are coming right up on the end of this 3-year pilot project. Total funding amount at $900,000 per year. So it was not a large grant. And I'm a one-woman show. And we can see the population and area served, but this is specific to pregnant and postpartum women who are access eligible and diagnosed with a substance use disorder, and really takes an intentional view and focus on the dyad of that mom, that parent, her family, and her baby, and supporting that baby and that mom through recovery. So I wanted to take a minute and just define some terms and some acronyms. I know we deal a lot in alphabet soup, so I wanted to just level set what we're talking about. So in this graphic, the largest red circle is substance exposed newborn, abbreviated as SEN. This is the general definition or diagnosis of a newborn exposed to any substance during the prenatal period. Within that full population of newborns, we have neonatal abstinence syndrome, which is NAS. This is the diagnosis given to a newborn who was substance exposed and is exhibiting signs of withdrawal. So any substance, but triggering signs of symptoms of withdrawal in the newborn, that will trigger diagnosis of neonatal abstinence syndrome. And then within that is a more discrete definition, neonatal opioid withdrawal syndrome, abbreviated as NOWS. And these are babies specifically exposed to opioids during the prenatal period. And these babies typically experience withdrawal symptoms. And so NAS and NOWS both refer to withdrawal symptoms. NOWS is specific to those symptoms caused by opioids. So just to level set. So why are we doing this work? Why are we focusing on this population in Arizona and nationally? And I wanted to share some data with all of you from the Arizona Neonatal Abstinence Syndrome Action Plan, which was convened in Arizona by Governor Ducey. And the outcome of this a couple of year-long task force is an action plan. And we looked at the data that we have and begin to understand the trends that we're seeing nationally. So we can see on the top line narcotic babies that have been exposed to narcotics prenatally, and then those diagnosed neonatal abstinence syndrome falling underneath, and then a subset exposed to opioids. And then you can see cocaine exposure and hallucinogenic exposure and fetal alcohol exposure below. Those trend lines are from Arizona from 2008 through 2014. And we know that as a nation, that data has just increased. And in Arizona, we have a significant challenge. So I have a timeline for this project, and I put a little note up here. This diagram was created. I built this in December of 2020. So this is a little bit of a walk down memory lane of really how this project rolled out in Arizona in response to that data of rising numbers of newborns having been exposed to opioids prior to birth. So I was hired in August of 2020. In that fall, we completed a statewide needs assessment. They're contracting for that, and it was completed in 2021. So it's available on the website for anyone who needs to use it. And then in the spring of 2021, we developed the PPW Learning Collaborative, and I met with many of you on this panel. And I'm assuming many folks attending really to learn about your work within the space of working directly with pregnant postpartum women. We did a lot of work of workforce development and capacity building and development of online trainings over the course of 22. And then in 23, I was hoping that we would get to a viable pilot treatment project to replicate this pilot. And I was hoping that we would have developed cross-sector relationships that will support pregnant postpartum women's recovery. And I'm quite happy to say that we are at that space. So these are what some of the points that we learned from our needs assessment. This should not surprise those of you who work in this space. We learned that 56% of women are afraid that if their providers found out about their substance use disorder challenges and requests for treatment, they would have their babies removed. Only 56% chose to respond to that question. 38% of respondents shared their substance use with their physician. The rest did not, out of fear. 20% of key stakeholders expressed agreement that they have the information they need, which means that nearly 80% of folks working this population do not have the information they need to feel comfortable and confident in treating the population. These are some system recommendations that the needs assessment led us to. And these are all really moving forward. I'm really working to expand screening for all pregnant and postpartum women, really working to make a no wrong door approach meaningful, and really looking to enhance the system of care. We know that stigma is a challenge. Stigma across systems, internal stigma. Women feel shame and guilt about their own substance use disorder, and they are on the receiving end of shame and guilt across health system settings, and significant fear of DCS involvement and loss of their parental rights. We're really working to change that systemically. There are a variety of trainings available. You have access or will have access to these slides. Brianna, you're free to share the deck that I sent out. These are two YouTube links that will take you to some really great content developed by Dr. Miriam Manriquez at the University of Arizona, specific to treatment within the population of pregnant and postpartum women with substance use disorder. And then we've learned that, well, we knew this already, but babies are babies actually, and they like to be with their moms. And in fact, that is the best practice. And we've known this for generations, centuries. We've known that babies need to be with their moms. We know that breastfeeding is the most appropriate feeding mechanism for babies. Human breast milk is made for babies, human babies. And we have research now that says this is actually the best outcome for moms and babies. And when we look at babies who have needed intervention with an opioid agonist, which is typically morphine, we can see the length of stay of those babies treated only with morphine on the blue line on the left. And then in this study, once they added in rooming in, and so mom was able to hold the baby and breastfeed on demand, the need for morphine reduced, and we can see the length of stay significantly reducing on the right. So this is emerging data that supports what we've always known about moms and babies, is that they do best together. So the Learning Collaborative meets monthly on the fourth Wednesday of the month. We have a couple of more meetings scheduled. I'm happy to connect you if you would like to be a part of this work with folks who are working directly with pregnant and postpartum women in this substance use disorder treatment and recovery space. We do this because recovery is possible. We all deserve do-overs. So thank you. That is my 10-minute bite-sized presentation. The coalition.
You did wonderful. I love that. I love your passion with all this here. It's amazing. Does anybody have any questions that they would like to ask Kate? So let me ask you a quick question on oral health and mothers and babies, and especially mothers with substance abuse. How can we improve the outcome of their oral health status?
So I think we need to remember that prenatal care is incredibly important for every mother, particularly pregnancies that are high risk. And if a mom has a substance use disorder, regardless of the substance, that pregnancy is at high risk. And so, yes, once she's connected to prenatal care, we really do need to ensure prenatal care is being provided, as well as an oral health care exam treatment. Treatment is not contraindicated because she's pregnant, or because she's pregnant and taking substance use disorder treatment medication, if that's her course of care. It is a myth that you cannot treat pain if a patient is on substance use disorder treatment or medications for opiate use disorder. It does merit a conversation about what that treatment, that pain control medication might be, but it does not mean that you cannot address oral health challenges or provide oral health education. And in my humble opinion, every mom and every baby needs access to dental health care, oral health care while mom's pregnant, and then education on the importance of newborn oral health, breastfeeding, all of that. And dentists and dental health professionals and dental assistants play a significant role in that education space.
Well, we thank you very much. So wonderful topic. Thank you very much for presenting for us today.
Absolutely. Thanks, everyone.
Our next presenter is Dalila Guerrero. Dalila Guerrero began her Maricopa County public health career in the September of 2003. The first position she held was as a community nutrition worker with the WIC program. Since then, she has held a variety of positions, such as a community health worker at the South Phoenix Healthy Start, administrative assistant with the Community Health Services, program assistant with First Oral Health, Program Coordinator, Cavity Free Arizona Dental Sealant Programs, Oral Health, and now Tobacco Regional Mobilizer, Office of Tobacco Prevention and Cessation. Dalia's passion for community overall health and access to care has helped her to be successful within the Maricopa County Department of Public Health for almost 20 years. Thank you, Dalia.
Thank you, Tammy. Again, my name is Dalila Guerrero, and yes, I am a tobacco-free regional mobilizer with the Department of Public Health for Maricopa County. My slides are up, but I don't think that's the first one. There we go. So again, I'm with the Office of Tobacco Prevention and Cessation. Next slide. All right, so we recently went through another department-wide reorganization. So our office now falls under the HOPE division, which stands for Health Outreach, Partnerships, and Equity. And as you can see on the very first column, that's where you can find me under the Tobacco Regional Communities group. And we do work closely with the PSC team, which stands for Policy, Systems, and Environmental, as well as the Youth Programs teams. All right, next slide. Let's see. So our youth program team coordinates 3 different youth coalitions: EYL, STAND, and YAC. YAC stands for Youth Advisory Council, and as a matter of fact, right now we are accepting applications for youth 14 to 18. So if you scan that QR code, it will give you more information about the Youth Advisory Council. It is all online, and the application is for the 23-24 school year. It doesn't necessarily need to be all tobacco focused. The applicants that apply must be interested in learning about public health in general, new skill sets, youth advocacy, and collaboration with community partners. The deadline is next week. So next Friday, May 26th will be the deadline. Next slide. All right, our PSC team has been working with the City of Phoenix Parks and Recreation Department. And what they have done is incorporated tobacco-free parks. So this also includes signage on all of their pavilions in their 180 parks around the city, and online training for all of their park rangers and tobacco cessation resources on their webpage. Next slide. Another component to our PSC team focuses on cessation efforts within behavioral health and justice-involved populations. Various trainings like Ashline referrals, basic tobacco intervention skills, and Dimensions group trainings are provided. Next slide. And the best for last, just kidding. That would be our tobacco-free regional mobilizer team, which I'm a part of. Jocabed Hernandez is assigned to the West Valley region. I am assigned to the Central/Phoenix region. So anywhere from North to South Phoenix is my region, and our East Valley region position is currently vacant, but we are interviewing for this position right now. Next slide. So what is our role as regional mobilizers? Oh, sorry. Can you click? There you go. All right. So first, schools are one of our main focuses. We provide evidence-based vaping prevention and alternatives to suspension curriculums. We also provide mini grants to schools looking to either incorporate or enhance what they're already doing in regards to tobacco and vaping prevention and diversion. As well as awareness on the Ashline's My Life, My Quit services for teens. Our tobacco-free collaborations, internally, we collaborate very closely with our equity managers as well as our regional liaisons, and external different coalitions and community organizations to provide Ashline support, which can come in any form as far as trainings or materials. And we have been working with ASU CERC to complete a community readiness assessment. And we recently received the report from ASU, which showed us that there is very low readiness when it comes to knowledge or awareness of our Ashline or other quit programs in our communities. So that was great information. It was a little disappointing, but great information, which will help us move forward in providing mini grants in the future in this area of, Ashline awareness or adult quit programs. All right, next slide. So speaking of our Arizona Smokers Helpline, Ashline, they are now contracted with the National Jewish Health, which has added additional services, individualized services in the areas of behavioral health, as well as the Native American community. The Native American community also will receive coaches that are Native American. So I think that is awesome. The middle flyer that you see there is our My Life, My Quit, which is for teens. They offer now texting and web chat. The next one is for young adults, and the last one on your screen is focusing on pregnant and postpartum women. So all 5 of these areas receive additional services in addition to the regular replacement, therapy tools and resources that Ashline already provides. I am not going to read all of this. I just wanted to put this slide in here because you all know, I'm sure you all know about this. So again, I'm not going to read through it, but I did want to include this slide, especially because that picture on the screen is one of my favorites. All right, so next slide. Okay, so this is one of my favorites because I was with the Maricopa County Office of Oral Health, and one of my first projects was collaborating with the cavity-free AZ dental sealant program. We created a slide that was incorporated into the district nurse back to school meetings. We offered flyers that you see here on your screen on the left-hand side that were passed out to the school nurses as well as the teachers when they were receiving their consent forms. The slide on the right is the slide we created for the 6th grade oral health education. They have a presentation, a 10-minute presentation that they provide to 6th grade, and we created this slide for that presentation to make the 6th graders aware that smoking and vaping can increase the risk of developing cavities. All right, next slide. All right, so oral health facts. Cigarettes, smokeless tobacco, and other forms of tobacco cause oral cancer, gum disease, and other oral health problems. Adults age 65 and older who smoke cigarettes are twice as likely to have untreated tooth decay as those who never smoked. About 43% of adults age 65 and older who currently smoke cigarettes have lost all of their teeth. Use of smokeless tobacco is associated with increased risk of oral cancer and can cause wider gray patches inside the mouth. And my favorite that I want everybody to pay attention to, healthcare providers in a variety of settings play a critical role in helping people quit using tobacco. So with that being said, if you think that there might be a way that we can collaborate and collaborate with your practice or your program, please do not hesitate to contact me so that we can chat and throw out different ideas on how our office can support you. Next slide. Oh, these are just the references. And that's it.
Thank you. Thank you very much for your presentation. Very, very nice. I like that you did talk about vaping as a big part of it. When you talk about being able to have you come to other dental practices, how do we go about getting in contact with you for that? Like, so for a private practice or anything like that?
So my contact information was on the last slide, but I'll also add it to the chat. And I believe the slides will be provided to everybody, but if not, I'll add my information to the chat.
And will you go into community health centers like FQHCs and stuff to talk about it as well?
Absolutely. We have different presentations that we can alter to meet the audience's needs. So I'm actually currently working with the Arizona Arizona, oh my gosh, I just forgot their name. Indian Coalition, the Urban Indian Coalition of Arizona. We're working together to create some trainings in regards to commercial tobacco and traditional tobacco. So it really just depends on what you're looking for, but we are here to help with your specific audience.
Well, thank you very much. So you'll go and put that in the chat and people can contact you if needed.
Yes,
Thank you.
absolutely. Thank you.
All right, now we have Dr. Scott Howell. And Dr. Scott Howell is an associate professor and director of public health dentistry and teledentistry at A.T. Still University, Arizona School of Dentistry and Oral Health, clinical advisor for Mouthwatch, and a senior Atlantic Fellow for Health Equity. He graduated from A.T. Still and ASDO with an MDM and an MPH program in 2014. He returned to A.T. Still and ASDO in 2015 to develop a teledentistry program. Interested in learning more about the broader aspects of oral health, he completed a dental public health residency at UT Health San Antonio in 2019 and became board certified in dental public health in 2020. Congratulations, Scott. That's really nice. All right, so he's going to talk all about teledentistry.
If you haven't heard me talk about teledentistry in the 7 or 8 years that I've been working in Arizona doing this, it's a pleasure to meet you, at least virtually. We did a small project over the past year with one of my students. She was getting her DMD MPH and she's wrapping up her graduation requirements right now. So for her MPH, that is. So I want to thank Dr. Tani Kumar for helping me with this, because I keep saying we aren't ready, or we're missing a lot of fundamentals for teledentistry in Arizona, but you need data to back it up. So here are some data to back up those claims. What we did is we sent out, using stakeholders like the Arizona Oral Health Coalition, the Arizona Dental Association, Hygiene Association, the community colleges, as many people as we could, to assess teledentistry use within Arizona amongst any provider who is working in Arizona. Whether they've used teledentistry, they've never used it, they previously used it, they're currently using it. We wanted as much information as we could gather. We had this open for about 1 month. The surveys from the different stakeholders didn't go out at the same time necessarily, so we kept it open for about a month to try to get as many responses as we could. I'm just going to go through some of the basic counts and percentages. We didn't really do any analysis like, ooh, why is this happening this way? These are just pretty much the raw data as is, because that's what we wanted to look at. So it was a smaller response rate. We would have loved more, but Tani's goal was 20 people. We got 15. One person didn't qualify because they weren't practicing currently in Arizona. So we got 14 responses, but we got a mix of responses, which does make me happy. You can see the counties that were represented and the different, whoops, I spelled rural wrong, but you can also see the different locations that people are represented in terms of where they come from. So it's a decent mix. I would have loved to see more counties represented, but that also could be, well, it's indicative of any number of things. Maybe those folks weren't on the list that we sent them out to. Maybe there are no providers, as we know. In some counties, there are very little, if no providers in those counties. And of course, not surprising that the majority came from Maricopa. We asked whether people were a provider, whether they were an owner, and so forth, and you can get a sense of some of the breakdown here. So we had people who do see patients, who don't see patients, owners, non-owners, and so forth. We didn't break it out by hygienist, dentist, well, soon to be dental therapist, although they aren't currently practicing in Arizona. We were more interested, it wasn't about necessarily the specific profession one was in, because as I tell people, teledentistry is for all our patients. It's also for all our providers. It's not just for the dentist. It's not just for the hygienist. It applies to anyone in any position. Maybe we could have broken that out. We didn't. You can see how we did, though. We asked providers, where are your patients coming from? And we can see that providers, the furthest distance that people are coming from in some of the clinics is upwards of 40+ miles. It's not as much when you average it out in terms of where everyone is coming from, but there are still people traveling long distances to see the providers that didn't respond. And you get a sense of the different clinics. And I have to give a shout out to the hygienists, because I know that the school-based clinics are primarily run by hygienists, and so they really came out and helped us out with this survey, so thank you. But I also love to see that we did get a mix of different folks. Those that worked in academic settings, we didn't specifically ask hygiene or dental, but given that I'm probably the only one at ASDO doing this, and I don't know if Midwestern is, I don't think the dental schools would have responded, but the hygiene schools I can't speak to in terms of which ones did respond. When you look at some of the practice demographics, diving into what insurances they're taking, it just gives you a breakdown of where the payments are coming from. And not surprising that most people, or the larger numbers of individuals, do not take Medicaid. Most respondents that responded said, we don't even take this. But it is nice to see that there are a number of respondents where that this is their primary payer, although not surprising given that we worked with, we're talking to school-based programs, FQHCs, IHS, and so forth. It's also not surprising that cash is the number one in terms of 76% plus in terms of the clinics that are taking it. It is one of their primary components. And again, I wanted to show this because access policies are some of the major barriers. So I was sort of curious, how is it all breaking out? When we broke it out to who is using it, because we wanted anyone who is currently using, previously used in their current clinic, not any previous clinics. We specified current clinic or never used. Remarkably, and actually not remarkably, the greatest number was never used. However, I was also surprised at how few were currently using, just because of the boom in teledentistry from COVID, but no doubt it's died down a bit. In fact, keep your eye out for either the August or September edition of the Journal of the American Dental Association. I worked with the ADA to develop a similar survey. They based some of their questions on the Arizona survey that we conducted, but they surveyed dentists across the country. And there's some interesting findings coming out from that in terms of teledentistry use amongst US-based providers. Dentists, I think the only dentists were able to respond to that. So keep an eye out for an upcoming edition of JADA. So why did the current and previous users use it? This is also stuff that doesn't surprise me. Dental problems, limited exams are kind of one of the easier things to do. We use it when we did a similar survey of our teledentistry activities for our on Zoom activities, not the parts where we send hygienists out into the community, but when we're just meeting on Zoom, because that is the most common belief that's the only way to use teledentistry. And this group probably might know that teledentistry has numerous ways to be used, but because of COVID, people thought, oh, it's just meeting on Zoom with my patient. It's not. It's so much more than that. But with that said, I'm also not surprised to see the limited number of people, sending a non-dentist into a community location. Like I know Dr. Hillier does that, and we do that. It was pretty cool, though, to see integrated dental and medical clinic. But again, nothing is surprising me. I just needed the data to demonstrate what's going on. This, I will say, this did surprise me. Even though I just said nothing surprised me. So I guess, no offense to Dr. is it Shaw, but I guess I'm a good politician because I just told you one thing and then turned around and told you another. Yes, this surprised me because 6 out of the 8 people who never used teledentistry reported that they had training in it. So I'm looking at that like, well, why didn't you want to use it? There were 4 people out of all the groups, the training or the currently using, previously used, not used, that said no training. We didn't break it out by that in terms of, you know, those who are currently using it. Why aren't you, or why, you know, you didn't get training? And I'd be kind of curious, well, how did you get into it then? But there's something's missing then, because if people are getting the training, but they've never used it, what's going on with the training? Again, these are just asking more questions, but I think it's going to lead to more discussions. Patients, we asked the providers, those who are current and previously used, what are some of the barriers that patients are overcoming for those who prefer telehealth, family and childcare needs? That's great, because it's great that people are able to overcome that barrier. It's expensive to go to the dentist when you have to take time off work, find childcare, whatever the case may be. Long distance from clinic. Again, not surprising, telehealth is a great mechanism to connect with people over long distances, but also short distances, because I've had patients say, you know, I only live 10 minutes from your clinic, but it really helped that I didn't have to physically drive in for my post-op visit because of XYZ reasons. And then again, no surprise here, COVID is the reason that most people started hearing about teledentistry, even though the modern form of teledentistry has been around since the late 80s, early 90s. Why are those who, what are those barriers for those who aren't using it or currently using it or previously used it? Reimbursement is my #1 issue that I'm struggling with. I'm curious about the technology issues, because the technology is pretty straightforward. There's some great technologies out there, unless it's related to systemic infrastructure issues, and that is lack of internet, which is going to be a big issue for our rural communities. Provider issues would be an issue around providers being available, being interested, and so forth. Perceived benefits by those who were using it, as you can see here, there are some great benefits. I thought this was interesting, though, that that reduces patient anxiety was one of the top ones, but you can see the rest here. And then the reason for not using it, I want to highlight, not many patients require it. That tells me that people don't know how it can be used, because I can find a reason for every single patient that walks into the office. Patients prefer to be seen in person. Yeah, if you haven't given them the option to telehealth, they won't even know. And then we also asked about ethical issues. I'm going a little fast here just for sake of time, but I also know that you don't need me to read through everything. So please feel free to pose questions in the chat if there's anything you'd like to see again. There were 5 of the previous and never. We didn't ask this question to current, and I'm realizing we probably should have, but there were 5 responses from the previously used and never used about ethical issues. And the only one that I would have trouble addressing right now is the 3rd one. I can teach people how to get all the information. I can also recommend, identify when you don't have enough information. That's part of the telehealth training. I can address inability to adequately assess. I can address HIPAA and confidential misdiagnosis. I can address all of those. This, however, is an example of when fraud could be used. And I do have a problem with this. Access's response was unique, and I think it's a decent response. We're not going to go into those details right now, but I think there needs to be more conversations with the payers. I absolutely do, to avoid this type of ethical issue. So what comes next? We got to continue educating people on the full range and use of teledentistry. There's a lot of misconceptions about how it can be used and what it can be used for. We got to continue advocating for those changes. So really tying into what we've been talking about today, the policy, the legislation is there. The legislation is there. Unless we want to put in the legislation that we absolutely need all teledentistry use to be reimbursed and not allow access to pick and choose what they want to do. Maybe work with the dental board to create some standards so people know how to use teledentistry. And then we've got to keep teaching it, particularly to our hygiene schools, because hygienists need to understand how to use teledentistry. But I know it's tough with the limited time and curriculum. I know that was a lot in a very short amount of time, but I hope it summarizes, gives you a sense of where we're at in Arizona. Thank you for your time, and thank you for letting me go a couple minutes over.
Oh, no, it's okay. So does anybody have any questions they might have for any of the 3 bite-sized webinar individuals that talked today? You can unmute yourself, ask any questions. Here's your opportunity. You've been silent this whole time. Sounds like how did Mary Bush always used to say, sounds like crickets.
I learned give people 7 seconds. I can't remember. I learned this from a career coach. People need 7 seconds. So you say any questions and count to 7. So I encourage everyone to try that in their future meetings.
All right, let's
If
count to
if
7.
you have if you're a participant, I don't know if you can unmute yourself, so just raise your hand and I'm happy to allow you to talk. Julia says in the chat.
Yeah, you know, it seems like all the CMS regulations around telehealth are really more geared towards telemedicine. I've had some conversations with CMS folks, and just teledentistry doesn't really seem to be on their radar. So I don't know. And since we don't bill Medicare, I just don't, I mean, we can, there are some supplementary plans. I just don't think that's going to impact us because our laws in Arizona were already in place prior to COVID. And we have some good laws in place. I don't think so. I hope not. The only thing I could possibly see changing is the opioid prescription. But when I work with people, I'm not recommending to prescribe opioids over teledentistry unless it's using teledentistry unless it's an established patient, it's a chronic pain management situation, and that would be limited to a very few number of providers.
Yeah.
Jimmy, I want to weigh in, and I just want to say, this is Kate. I just want to say thank you for that, Scott. So another couple of hats that I wear at Access are really around medications for opiate use disorder and prescribing, and sort of navigating our state's understanding collectively of who the prescribers are, who could prescribe an opioid, and dentists can, among a set of other providers, but dentists can. And I think that that's one of the questions that we get sort of the system level, is that when we're talking about needing to be sure that patients who are in substance use disorder treatment and receiving medications for opiate use disorder, or maybe at risk for or would benefit for being referred and connected in to chronic pain management or to substance use disorder, dentists and dental hygienists and dental assistants and the whole team is a really great connection point. Because typically there's a greater level of trust around substance use disorders with your dentist and other stuff you're doing while you're leaning back, getting your teeth cleaned and chit-chatting away. That's an opportunity to make a connection. And it's also an opportunity on the professional development side for dentists to become more aware of substance use disorder treatment and medications that are available, and to keep an eye on the flexibilities and changes with the public health emergency ending and Medicaid unwinding and those changes. So thanks for recognizing that, Scott, and connecting.
Yeah. I will, this is a bit off topic, but because you mentioned substance use disorders, I encourage everyone to start learning, if you haven't, about the drugs that are getting to our patients. We are moving away from the plant-based drugs like heroin and cocaine. While those are dangerous, it is the synthetic drugs that are cheaper, easier to get into the country. They're cheaper to make. They can make much larger amounts of them. If you aren't up to date on your substances that are out there, you probably aren't asking your patients enough questions. So please, please, please learn as much as you can, because there are some nasty drugs making their way out there.
Nasty drugs. Well said. So I will, again, not necessarily on point here, but close. I will be, there will be updated information around fentanyl, and around xylazine.
Thank you.
Be
Yeah, that's
looking
awesome.
for materials around xylazine. It does not act as, it's not an opioid, so it doesn't act the same way.
It's a horse tranquilizer is what it is.
Horse tranquilizer, and it is making its way into the drug supply. Folks don't know that they've ingested it. Neither do their friends. And so naloxone doesn't have its expected recovery reaction. And first responders are not necessarily prepared because nobody's thinking about or testing for xylazine because we're thinking about fentanyl and opioids, and it's not an opioid. So yes, please get up to date with your, thanks for the link. Please get up to date with substances that are out there and recommended for first response medications and actions.
Yeah, this Time article just came out yesterday. I haven't read it, but I just typed in xylazine and Time, I would trust Time. So
yeah, this is a hot topic on the SAMHSA front. So yes, Brianna, all of those resources that I get, I will continue to send. And Tammy, to your question, there are webinars available and out there linked are specifically connecting oral health and behavioral health. So Scott, this may get to some of these are the questions, these are the motivational interviewing tactics, techniques, questions, scenarios you need to be thinking about because it's very real and very deadly.
And Access does reimburse for the smoking cessation and substance abuse cessation or substance use cessation codes. Of course, it's only going to be for our younger patients because of the access restrictions. But if you simply ask, do you want to talk about smoking cessation? Do you want to talk about stopping to use drugs? You can use that code and get reimbursed. It doesn't have to be a long, lengthy conversation. You just have to start the conversation. And I think that is wonderful.
The ESPER, yes, brief, short intervention, connect to resources, and then know that substance use treatment is available for anyone in our state who needs it, Medicaid eligible or not. It is completely covered. So substance abuse block grant treatment resources are available statewide. So if a patient, regardless of their insurance, indicates a need for treatment or a desire to talk to someone, please connect them. There is availability.
No, we weren't talking opioids today, but hey, it's an emerging public health crisis. Not even it is. It's getting worse. So
it's getting worse.
Yeah.
And regardless of the substance. So I am also seeing an increase in folks talking about methamphetamines, an increase in other stimulant disorder as well. So we'll be looking for those fact sheets and tip sheets coming out from SAMHSA with updated information as well.
Thank you. Do we have any other questions for any of our people? Wait 7 seconds. Thanks, Scott. That helps. I really appreciate everyone being a part of this today. We covered a lot of material in a short amount of time. Feel free to reach out to any of us on the coalition, and we can help you with connecting you with the right people. We really enjoyed this event. We enjoyed it just as much as putting it together. And I'm going to miss being around everybody and so much getting this all together. And thank you for taking your time out of your busy schedules to come and hang out with us today. Do you, Tara or Sandy or Brianna, do you have anything you want to say?
Just thank you, everybody. I think I really enjoyed just connecting with you all and great conversations in the chat. And we look forward to hosting more events to connect with you all in the future. Have a great weekend.
Wonderful. Yeah, take care, everybody. And go out there and champion oral health. Woo! Woo! Thank you.
Bye, everybody.
Bye.
Have a great weekend.
Bye.
Bye-bye.